Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 211 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, J.A.P. is a 58-year-old male patient admitted to the trauma surgical ICU following a motor vehicle collision resulting in multiple trauma, a broken femur, radius fracture, and multiple facial lacerations. The orthopedic surgeon took him to the operation room where his leg was repaired. J.A.P. is now intubated in the surgical ICU and is extremely agitated. J.A.P.'s blood alcohol level on admission was 420 mg per deciliter. He has a history of alcohol withdrawal seizures. So my question to you is, which of the therapeutic regimens listed below would be most appropriate initially for J.A.P.? Would it be A. haloperidol 5 mg IV every 2 hours PRN for RASS above 0 and thiamine 200 mg IV once daily? Or B. phenobarbital 65 mg IV every 2 hours as needed for CIWAAR above 10 and thiamine 500 mg IV once daily? Or C. lorazepam 1 mg IV every 2 hours PRN for RASS above 0 and thiamine 100 mg IV OD? Or would it be D. dexmedetomidine 1.2 micrograms per kilogram per hour by IV infusion and thiamine 100 mg IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. lorazepam 1 mg IV every 2 hours PRN for RASS above 0 and thiamine 100 mg IV once daily. Dexmedetomidine has been studied as an adjunctive therapy in patients with severe alcohol withdrawal symptoms that are unresponsive to benzodiazepines, but data are lacking to support its use as a first-line agent. Benzodiazepines are first-line treatment for severe alcohol withdrawal, and thiamine 100 mg IV daily is appropriate to prevent Wernicke's encephalopathy. Phenobarbital can be considered an alternative to benzodiazepines for treating severe alcohol withdrawal, but most ICU research has evaluated its use in combination with benzodiazepine therapy rather than as monotherapy. Thiamine 100 mg IV daily and not 500 mg daily is appropriate to prevent Wernicke's encephalopathy. Haloperidol monotherapy would not be an option for J.A.P. because it is not a first-line agent for treating alcohol withdrawal symptoms, and it can lower the seizure threshold. Additionally, the symptoms that J.A.P. is experiencing are more amenable to GABA-based therapy. Thiamine 100 mg IV daily and not 200 mg daily is appropriate to prevent Wernicke's encephalopathy. Please proceed to the next question. And the next question reads, TAC, a 65-year-old patient is admitted to your medical ICU and is given a diagnosis of severe community-acquired pneumonia. TAC has a past medical history significant for end-stage cirrhosis. TAC's pertinent labs include serum creatinine 2.1 mg per deciliter, which is an increase from a baseline of 0.9 mg per deciliter at the time of admission to over the course of 10 days. So my question to you is, which of the following would be the best evidence-based treatment goal for TAC? Would it be A. decrease in bilirubin by 50%, or B. increase in mean arterial pressure by at least 10 mm of mercury, or C. increase in urine output to 1 ml per kilogram per hour? Or would it be D. increase in urine output to 0.5 ml per kilogram per hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Increase in mean arterial pressure by at least 10 mm of mercury. TAC has type 1 hepatorenal syndrome, abbreviated as HRS, because of the doubling of the serum creatinine. Increasing the urine output has not been evaluated as a treatment goal in type 1 hepatorenal syndrome. The best evidence suggests that an increase in mean arterial pressure (MAP) by at least 10 mm of mercury is associated with improved renal outcomes and a higher likelihood of reversal of type 1 hepatorenal syndrome than smaller increases in MAP. Decreasing the bilirubin has not been evaluated as a treatment goal in type 1 hepatorenal syndrome. Please proceed to the next question. And the next question reads, G.S.P, a 69-year-old female patient admitted to your medical ICU for acute respiratory distress and failure to thrive. She has a past medical history significant for alcohol withdrawal, and COPD. G.S.P reports a decrease in appetite and unintentional weight loss from 140 pounds to 125 pounds over the 120 days prior to this current admission. So my question to you is, which of the statements listed below about G.S.P's risk of refeeding syndrome is true or accurate? Is it A. G.S.P is not at high risk for refeeding syndrome because her recent unintentional weight loss is not large enough to meet the accepted threshold? Or B. G.S.P is at high risk for refeeding syndrome due to her COPD and recent unintentional weight loss? Or C. G.S.P is at high risk for refeeding syndrome due to her recent unintentional weight loss alone? Or is it D. G.S.P is at high risk for refeeding syndrome due to her recent unintentional weight loss and history of alcohol abuse? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. G.S.P is at high risk for refeeding syndrome due to her recent unintentional weight loss and history of alcohol abuse. G.S.P meets the National Institute for Health and Care Excellence criteria for a high risk for refeeding syndrome, a greater than 10% unintentional weight loss within 3 to 6 months and history of alcohol abuse among other criteria, because of her 11% weight loss over 4 months and history of alcohol withdrawal. The amount of weight loss, that is 11%, alone in G.S.P isn't sufficient to meet the National Institute for Health and Care Excellence criteria for a high risk for refeeding syndrome. If weight loss is the only risk factor for refeeding syndrome, the threshold is a 15% weight loss over 3 to 6 months. COPD is not a risk factor for refeeding syndrome. G.S.P meets the two National Institute for Health and Care Excellence criteria for a high risk for refeeding syndrome, having both an unintentional weight loss of greater than 10% over 3 to 6 months as well as a history of alcohol abuse. Please progress to the next question. And the next question reads, G.S.P in the case above is initiated on enteral feedings on day 2 of her admission, and the rate is up-titrated to the goal rate over the course of 24 hours. So my question to you is, which of the conditions listed below would be the most likely to result from this nutrition strategy? Would it be A. hyperkalemia, hyperphosphatemia, and hypomagnesemia? Or B. hyperglycemia, hyperphosphatemia, and hypomagnesemia? Or C. hyperkalemia, hypophosphatemia, and hypomagnesemia? Or would it be D. no electrolyte abnormalities are likely because this is an appropriate nutrition strategy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. hyperkalemia, hypophosphatemia, and hypomagnesemia. G.S.P is at risk for refeeding syndrome because of the aggressive rate of titration of her enteral feedings, starting at 10 kilocalories per kilogram per day and up-titrating over 4 to 7 days is more appropriate than 24 hours, and her history of alcohol abuse and recent weight loss. Refeeding syndrome is characterized by reductions in serum phosphate, potassium, and magnesium, with hyperkalemia, hypomagnesemia, and hypophosphatemia, not T-hyperkalemia, hyperphosphatemia and hypomagnesemia. Please proceed to the next question. And the next question reads, BKB, a 58-year-old male patient is admitted to your medical ICU for acute hematemesis and suspected variceal bleeding. He has a history of alcoholic cirrhosis and ascites. His pertinent vitals include a blood pressure of 100 systolic 50 diastolic, a heart rate of 110 beats per minute, a body temperature of 101.1 degrees Fahrenheit, a respiratory rate of 25 breaths per minute. His pertinent labs include a hemoglobin of 6.5 grams per deciliter, a lactate of 1.2 millimoles per liter, serum creatinine 0.9 milligrams per deciliter. At baseline it was 0.9 milligrams per deciliter. So my question to you is, which of the interventions listed below has been demonstrated to reduce mortality in patients with variceal bleeding and should be recommended in BKB's clinical scenario? Is it A. Pantoprazole 80 mg as an IV bolus followed by an 8 mg per hour infusion? Or B. Octreotide 50 micrograms as an IV bolus followed by a 50 micrograms per hour infusion? Or C. Norepinephrine by IV infusion titrated to a mean arterial pressure of 80 mm of mercury? Or is it D. Ceftriaxone 1 gram IV once daily for 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Ceftriaxone 1 gram IV once daily for 5 days. BKB has cirrhosis with GI bleeding. There is good evidence demonstrating that prophylactic antibiotic therapy reduces the rates of rebleeding, infection, and mortality in patients with cirrhosis and GI bleeding, both variceal and non-variceal. Therefore, ceftriaxone is the best choice for BKB. There is no evidence that targeting a mean arterial pressure of 80 mm of mercury improves outcomes in patients with variceal bleeding. There is no evidence of a reduction in mortality from the use of octreotide in patients with variceal bleeding, although a reduction in rebleeding episodes has been demonstrated. Acid suppressive therapy has not been shown to reduce mortality in patients with variceal bleeding. Please proceed to the next question. And the next question reads, TPY, a 56-year-old male patient presented to the medical ICU with acute esophageal variceal bleeding that was managed by ligation by the general surgeon. He has a past medical history significant for cirrhosis and ascites. After 2 days of his hospital stay, the clinical team feels he is ready for transfer to the floor. After reviewing his medical chart, you notice that TPY is currently receiving Octreotide at a rate of 50 micrograms per hour via IV infusion. So my question to you is, which of the therapeutic regimens listed below would be the most appropriate for TPY to minimize his risk of recurrent bleeding on the floor? Would it be A. Change Octreotide to 50 micrograms subcutaneously thrice daily and add Pantoprazole 40 mg IV twice daily for 5 days? Or B. Continue the Octreotide infusion for a total of 5 days? Or C. Add a Pantoprazole 80 mg IV bolus followed by 8 mg per hour IV infusion for 5 days and continue the Octreotide infusion? Or would it be D. Add a Pantoprazole 80 mg IV bolus followed by 8 mg per hour IV infusion for 5 days and discontinue Octreotide? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Continue the Octreotide infusion for a total of 5 days. Pantoprazole, and other acid suppressive therapies, has not been studied in patients with variceal bleeding. It has only been shown to reduce the risk of recurrent bleeding after endoscopic management of ulcerative bleeding. The period of highest risk for recurrent bleeding is the 5 days after endoscopic therapy, i.e., ligation, for esophageal varices. Giving Octreotide for 5 days after endoscopic therapy has been shown to reduce rates of recurrent bleeding. Octreotide 100 to 200 mg subcutaneously 3 times daily is the appropriate dosage of the somatostatin analog. Please proceed to the next question. And the next question reads, HTF, a 46-year-old male patient was admitted to your medical ICU for alcohol withdrawal. Since admission 14 hours ago, HTF has remained extremely agitated with a Richmond Sedation Agitation Scale (RASS) score of +3. His pertinent vitals include a body temperature of 99.1 degrees Fahrenheit, a blood pressure of 125 systolic 80 diastolic, a heart rate of 84 beats per minute, and a respiratory rate of 20 breaths per minute. HTF is currently receiving oxygen 2 liters per hour by nasal cannula, and he requires frequent nursing intervention to prevent him from crawling out of bed. His current medications include lorazepam IV infusion at 4 mg per hour, with 2 to 4 mg IV every 10 minutes PRN for agitation. So my question to you is, which of the options listed below would be the most appropriate to promptly control HTF's agitation? Would it be A. Begin valproic acid 500 mg orally or by nasogastric tube twice daily? Or B. Add IV propofol starting with 5 micrograms per kilogram per minute and increasing in 5 micrograms per kilogram per minute increments until agitation is controlled? Or C. Begin dexmedetomidine 0.4 micrograms per kilogram per hour IV and increase the rate every 30 minutes to the desired RASS score? Or would it be D. Increase the lorazepam infusion to 6 mg per hour? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Begin dexmedetomidine 0.4 micrograms per kilogram per hour IV and increase the rate every 30 minutes to the desired RASS score. Increasing the lorazepam infusion rate would not provide an immediate benefit in controlling the patient's agitation. Dexmedetomidine has been used in many case series and case reports of alcohol withdrawal symptoms that are severe or refractory to benzodiazepine therapy. These reports suggest that the drug adds to symptom control and reduces benzodiazepine dosing requirements. This patient is not intubated, so propofol cannot be used safely. Valproic acid has been studied in patients with mild or moderate alcohol withdrawal symptoms, but there are no data supporting its use for alcohol withdrawal symptoms in ICU patients. Please progress to the next question. And the next question reads, regarding HTF above, what additional laboratory monitoring would be useful during lorazepam therapy in HTF's clinical scenario? Would it be A. serum osmolarity, or B. serum bilirubin, or C. serum aspartate aminotransferase AST, alanine aminotransferase ALT? Or would it be D. serum sodium? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Serum osmolarity. IV lorazepam does not cause disruptions in sodium homeostasis. IV lorazepam is not hepatotoxic, so liver enzyme monitoring is not needed. IV lorazepam is not hepatotoxic, so serum bilirubin monitoring is not needed. Serum osmolarity is an important value to monitor in patients receiving high-dose IV lorazepam, which contains propylene glycol. Continuous infusion of lorazepam or diazepam may result in hyperosmolar anion gap metabolic acidosis. Once a serum osmolarity has been measured, it should be compared with the calculated osmolarity to determine the osmolar gap. Osmolar gaps exceeding 10 millimoles per liter indicate the potential for propylene glycol accumulation and toxicity. Thank you.